Okay. It is recording. Yay.
Okay, well, good evening, everybody. My name is Rebecca Altpeter. I'm the head of school at Dearborn Academy, which is a therapeutic day school that serves students with social, emotional, and learning needs. And I'm so honored to introduce our facilitators, Sheila and Dana, and our guest speaker when she arrives, Peggy Chapman. So first, Dana Mann is a licensed mental health counselor at Dearborn Academy. Dana graduated from Boston College and has experience working in hospitals, schools, and outpatient clinical settings. Among her many other responsibilities at Dearborn Academy, Dana co-facilitates our Caregiver Trauma Group, which is a 10-week group aimed at helping caregivers who have experienced complex stress and trauma from caring for a child with mental health struggles. Sheila, who has left, I believe, to go help Peggy. Peggy is the principal and clinical director at Dearborn Academy. She's also a licensed independent clinical social worker and educator with over 20 years of experience working with and advocating for students with complex mental health needs. Sheila has children who were ultimately diagnosed as PANDAS, which you're going to learn about tonight. And Sheila co-founded the Massachusetts Coalition for PANDAS legislation, which successfully championed the passage of both insurance mandate and established a permanent Department of Public Health PANDAS Advisory Council, where Sheila serves as co-chair. She received the 2020 Commonwealth Heroine Award and Boston College School of Social Work's Distinguished Alumni Award in 2024. And she is just a force for kids and families, and we're so lucky to have her. Peggy, who's going to be the headliner when she comes, is a clinical nurse specialist, board certified in child and adolescent psychiatric nursing. Peggy received her Bachelor's of Science in nursing at Creighton University in 1976. In 1982, Peggy graduated from Boston University with a Master's of Science in nursing and was certified as a clinical nurse specialist in 1983. Peggy has worked in various capacities in the Omaha and Boston areas, including as head nurse of child, adolescent, and adult psychiatric units, as a therapist for child, adolescent, and adults, and as a psychopharmacology specialist for all ages since 1988. Peggy co-led the Asperger Association of New England Parent Support Group for 11 years on the South Shore. And from 1999 to 2006, Peggy was a Defeat Autism Now practitioner. She treated her first PANS patient in 1999. Peggy currently integrates the principles of functional medicine into her practice and frequently presents to fellow professionals, parents, and educators regarding the use of nutrition and psychiatric pharmacology for children and adolescents. And most close to us, she has been instrumental in helping us achieve diagnostic clarity for a number of students at Dearborn Academy since she began consulting with our school in 2019. And I promise you're going to get to see her soon. You know any good jokes, Dana? Like,
nope. Off the fly.
Yeah, it's hard. Why was the math book so sad?
Why?
Had so many problems. You know, that's my one school joke that I can remember, and the kids never laugh.
It's a good one.
I know they want to. That's all I can remember. School jokes.
How many apples grow on trees?
You got me.
All of them.
That's good. I didn't mind it.
Good.
Sheila, do you have any jokes?
Peggy's laughing. She's coming. I think.
Her.
Yep.
Great. Are you
gonna come with the... Am I?
Well, I'm wondering if Sheila's playing tech support. She's good at a lot of things, but I wouldn't have put that on her.
That would definitely not be my forte. Yes, but no. But
you were a dedicated audience. People are staying. We appreciate you out there. Poor Peggy. She's probably very stressed.
I know. Nothing like a webinar without a tech issue. It's gotta happen.
I feel like we're about to see Peggy come onto the screen. I'll have to exit stage left because I have another engagement, but I will say hi to
Okay,
Peggy.
she's in. I'm just trying to promote her to panelist.
Great.
I don't know what's happening.
Yeah.
Okay, can I?
Peggy,
do
we
I-
hear you. We see
Hi,
you.
hi. You know,
Hi.
I'm really bad at technical. I can break anything they ask me to touch. So, am I now sharing my screen? Can I do that now?
You can.
Here,
We're
do you
so
see
proud to
that?
have you. And Rebecca already introduced you. You just weren't here for the amazing
See
introduction.
that?
What?
Do you see this? Do you see the slides now?
Nope. Hold on. I think I probably have to let you. Yep. It's great. Dana, what did we do last time?
I think I just did it.
Oh,
I think I
Okay.
just allowed for it.
You should be able to share now.
do I
Peggy.
share screen then? Do I hit it?
You have to hit it. Yep.
Okay, there it is. All right. All right. Now I'm going to-
Peggy Chapman's my hero.
Thank you,
Not
Peggy.
this moment, I'm not. Okay, get rid of that. All right, here we are. Let's see, go back. All right. Good evening, everybody. As soon as I can calm my anxiety and adrenaline down, I'll be much better. Okay, so I am talking about PANS and PANDAS tonight and trying to give you an overview. I'm trying not to get too specific, too scientific, or too in deep because it'll just make it harder. But there will be question and answers. And Sheila, if you please give me some timeline since we're running 10 minutes late. You tell me when we're close to the 20-minute mark or wherever you want me to go. But give me a 10-minute notice before we get there, if you could.
Yes, I certainly can. Yep.
All
Well-
right. All right. And what is this? What is this? Okay. So what is PANS and PANDAS? PANS is an acronym for, the computer keeps loading something. Hold on a minute. It must decide it wants me to do something else. Like Teams. Yes, there it is. Okay. Pediatric acute onset neuropsychiatric syndrome, which is an overarching statement for what you might have also heard as PANDAS, P-A-N-D-A-S, which is this illness specifically to streptococcal infection. Was also the original designated illness until 2012. It started by an article in by Susan Sweeto out of National Institute of Health in 1998 was their first publicated article, and then they updated it in 2012. What is it though? PANS and PANDAS is a condition where a subset of children and adolescents experience encephalitic-like, which is inflammation of the brain, onset of neuropsychiatric symptoms. And these symptoms occur following an infection, such as strep, mycoplasma pneumonia, viruses, mononucleosis flu, and I would add COVID here. COVID's been really nasty for a lot of people. And what happens is the antibodies react to, and I'll show you some description of this, but the antibodies react to this illness by creating antibodies, which is what they're supposed to do. But these antibodies become misdirected and attack a part of the brain, which I'll show you shortly, called the basal ganglia. This autoimmune reaction results in psychiatric symptoms called neuropsychiatric symptoms. and yet it is a medically driven illness. Both of these illnesses are diagnosed by clinical history and examination and not lab work, although lab work is used as a supportive element for kind of some confirmation if I'm looking for strep exposure, or perhaps tells me about things like autoimmune antibodies and some other elements that are helpful to know. This, everybody, is the basal ganglia. Is my arrow showing you? I hope. And it's the blue with the purple and yellow around it. So the blue is kind of basically, it's made up of a number of parts. And then in the front is the frontal cortex, which is where your brain and your thought process and your decision making is. The auditory system right behind it. Very importantly, what you call the amygdala is right down here, which is the fight-flight section. And the limbic system is the emotions. Back here is visual. Up here is motor.
Peggy, your
Yeah.
mic is a little muffled. I'm not sure why. I don't know.
My voice?
Yeah, your mic, like it's muffled. I don't know.
Let me try and turn it off and go on again. Hold on a minute.
Okay, that's okay. We'll just keep going, but just, okay.
Is it still bad?
It's a little bit better.
Okay, let me see if I can turn up my volume. I'm not sure that's gonna matter, but I'll try. The average age diagnosis is predominantly 4 to 9 years old and 4 to 13, really, 10 to 13, because these are the years where strep occurs. But in fact, it's also much more than that. We see it in young adults in their 20s going towards 30. We see it in younger children. At least we can track it back to when they were 1 to 3 years old, when they actually started having the illness. It's a spectrum, so it's very wide, and I'll show you a little more wide later in its presentation. In fact, there are many options to pick from in the diagnosis as to what it could be, how it expresses itself. Immune-based conditions are found in most of these families, about 71%. And can adults have PANS? Yes, they can. In fact, there is unfortunately a brain bank at Georgetown called the Brain Bank, and it has a brain of a 26-year-old who started having her symptoms at 19, diagnosed herself kind of, and shortly before she started treatment, she died. And her brain was autopsied, and it showed basal ganglia tissue damage. Now, it's not clear that the damage would be permanent or that it would be wasn't a part of the inflammatory process, but it was noted to be different. If you happen to know of someone, unfortunately, to lose their life from this illness, it's really important you spread the word as fast as you can if they can help with the brain. The diagnostic criteria are the following. Either one of these two items are the main ingredient, either a sudden onset of obsessive compulsive disorder, which includes things like inappropriate thoughts, rigid rules, repetitive actions. And also OCD in these kids does not always look like what you think it looks like to most of us. So OCD is kind of thought of as a touching, tapping, counting, hand washing, kind of illness. Often these thoughts are very intrusive, very upsetting, but they don't act out compulsions related to them. So suicide ideation, compulsions around foods, sensory issues, but basically it doesn't always look like what you'd see on television, and most physicians and practitioners even think of as you have to be doing something like washing, counting, touching, tapping, arranging things. But many times it's hidden inside of their brain. It's more obsessive and not necessarily compulsive acting. Or the compulsion is to think or act on it, but not in a ritualistic, continual way. The other option is a severely restricted food intake. This is now known as avoidant restrictive food disorder, or ARFID, in now the medical statements. When I first used to give this lecture, ARFID wasn't really even talked about. I'm not sure when it got identified. But it's a very narrowing of food choices, fear of choking, frank refusal to eat, will not swallow, spit, have panic overeating, often lots of food rules go into effect. In fact, it becomes very compulsive how they eat. And then it has to be accompanied by one of two of the following many symptoms. One of them is anxiety. Anxiety is huge. Generalized anxiety, phobia anxiety, separation anxiety, panic, agoraphobia, social anxiety, and probably others that I haven't even listed. Now, the problem is you have to kind of sometimes, for the practitioner, that's me, sort out if the anxiety is actually obsessional, as in bad things are going to happen if I do something like leave home, something bad will happen, or this extreme dread that they obsessively carry that if something's not right, it's going to be bad, really bad, like somebody's going to die or I'm going to injure somebody. This occurs with food, for example, which is if I swallow, I might poison my mother. And I have a saying that if you're under 12, they present as they can't leave the parent, often the mom. And if they're over 12, they just make all sorts of reasons they cannot leave the house. They stop going out, they start canceling friendship and sleepovers, things like that. Now, emotional lability is another one, and it's depression, bipolar presentation, mood disorder. Mood can be anywhere on the spectrum, and it can look hypomanic, manic for time, but then it doesn't stay there. And unfortunately, because of this, people get diagnosed with bipolar. They get diagnosed with DMMD, disruptive mood dysregulation, or DMDD, disruptive mood dysregulation disorder, which is kind of the minor version of bipolar. Many kids get all these diagnoses. Also, another section of 2 is irritability, aggression, and/or severe oppositional. So now we've got the mood, but it's accelerated. It's like a jet fuel under it. It's aggression, that bang, bash, break, hit. I had a complaint from a parent whose 5-year-old was beating her up. Now you'd ask, how does a 5-year-old beat up a mother? Well, they'd climb on top, they'd knock her over, climb on top of her and beat the crap out of her. And this kid was 5. And this was, of course, a brand new behavior, totally unexpected and horrifying to all involved. Very oppositional, some of them. Another one, behavioral developmental regression. They baby talk, they thumb suck. You just go, they tantrum like they're 2, and you go, why are they acting this way? This is not the child I knew. Very commonly, sudden deterioration in public performance, in school performance, sorry. They look like they often have ADHD symptoms, but many of these children don't have ADHD until they have this illness. They could have had ADHD all along, so then it gets a little murky what's happening. But also things they talk about a lot, the measure, and we see is short-term memory deficits. That's working memory, slowed processing speed. All of a sudden, they can't take it in at the rate they're supposed to be thinking about it. Executive function is really lost. So these are people who can't organize, even to the point they don't know how to get dressed. They can't get themselves together. They can't make a paragraph because paragraphs require first, second, third, fourth things in order. And they also have declines in visual motor deterioration. Visual motor impacts math and science hugely, or any diagram on a board that you have to look at and figure it out. I've had kids with math trophies on their bookcases and they can't, algebra looks like Greek all of a sudden. You'll see if you have comparative studies between prior, like if your child already has an IEP for, like, say, dyslexia, you'll see drops of these areas in their IQ scores. I just saw one yesterday. The drop was 50 points between their visual skills earlier and their current visual skills. This is how it looks in action. So this is visual motor writing changes. This is a child whose normal ability to draw beautiful microscope. This is, she can't make 3 columns and she can't, maybe that was a name there, or maybe it's just shield. You can't really tell. It's probably about a volcano. There's cinder cone, but you really can't know. Their lines are off. If you see young children, you could even compare coloring. Did they used to color in the lines, or can they now do it? Here's another one where this demonstrates during the illness how they can't organize, they can't connect, they very grotesque, carry really broad stroke, almost like this would be like a 2 to 3-year-old drawing, maybe barely 4, and here's her recovered drawing to give you the context. OCD is also accompanied by, or EC, again, these are all the things accompanying, these are choices. Motor abnormalities and sensory abnormalities. So this would include handwriting, as I mentioned, we know it as dysgraphia, where some kids already had that diagnosis. Choreoform, which I can't see me, but if you hold your hands out and start to play like you're playing the piano, that is a choreoform movement. That is specific to strep only, by the way. They're hyperactive, and sometimes they get so hyperactive they do backflips and spin and cartwheels in totally inappropriate places. I had a child who was backflipping so bad in his small pediatrician's office, and we had to take him out of the hallway because he would have kicked somebody doing it. Inability to dress, I mentioned, do regular activities. They don't shower, they don't brush their teeth. sometimes parents have to get them dressed. And motor and vocal tics can be extremely severe. But I want to make a point here that in 1998 to 2013, remember I said the diagnosis changed in 2012, it was around 2013 actually, that the PANDAS diagnosis then officially changed so that tics, which had been originally, the original diagnosis would either you had an initial onset of tics or OCD. Then they changed it and put tics down here and made eating disorder the top. It wasn't that the illness changed. It was a political decision because neurologists really rigorously fought that tics are not PANDAS. This is still a controversial issue with them, and because they wax and wane, as do PANDAS symptoms. And but these tics, when they come on and they come on suddenly, are debilitating often. And unlike Tourette or a tic disorder, which it's normal for kids to have tics like 5 to 7, and then if it's Tourette, it starts to develop often more, and then the vocal part comes in or the motor part comes in. And there's a whole diagnosis criteria for Tourette, but these kids like have Tourette's overnight. And therefore they're getting misdiagnosed because you have to have Tourette for 6 months before these tics, before you even get a diagnosis. They also have huge changes in lights, sensitivity issues, lights, noise, smells, taste, textures, sensory seeking behaviors, even having particular things to touch. They might be clinging to a blankie or a toy. I've known of kids who pack that toy to bring them to school. And often they're complaining about lights, how you chew, how you close your mouth. They can't eat with you. They can't smell foods they used to do. They can't taste foods. Things taste very different. They tend to also start to crave carbs and sugars. There's some biology behind that, which I'm fully not capable of explaining, but it is appearing in terms of food choices. Sensories include also, on a more extreme version, you can have psychosis in this illness. About 10 to 13% has been measured. Visual hallucinations are not uncommon when you're in this state, including very frightening images, altered perceptions, which was called the Alice in Wonderland distortion. I had a child she would sit in her closet because when she'd open the door, she was either a tiny little thing like a mushroom to her furniture in the room, or the furniture was like a little tiny mushroom to her big body. She literally was like Alice in Wonderland with her vision. And then children say it's like a nightmare when I'm awake. They also can see very scary images, such as their parents getting killed, their intruder, they got injured by an intruder. Auditory hallucinations don't happen as much. It's mostly visual, which, by the way, in psychiatry even, is often a question mark, and the type of the hallucination, like spiders growing on you. I just had a kid the other day, I worked up, she saw bugs in her food all the time. And so this is a visual hallucination. That kind of hallucination is usually neurologic. When my father-in-law was having sort of a brief dementia moment, he saw hangers hanging over the wall. He saw bugs on him. He was actually iron deficient when he saw bugs. So it's usually a neurologic or physical reason that visual hallucinations become this way. Urination and somatic. Somatic is the body. So now we have urination issues, urgency, wetting the bed or pants, frequent trips to the bathroom. When they're wetting, this is a child who's been dry. It's not a child who's still in that, sometimes at 12, up until 13, they're going to have enuresis at night because the family history is strong, the genetics are there. These are kids who've been dry. So if you see a kid who has been dry if I see a kid who's been dry at 2, totally potty trained by 3, and now they're starting to wet their bed at 5, you have to look around and say, what would that be about? Now, did they move? Yeah, but that would only be a couple transitions. Do they have a young sibling? Yes. But it is not to be continued if it's normal. Or if you're really, really tired, some kids are really heavy sleepers and it makes them harder to wake up. But this is different than normal. They're often checked for a UTI. So when I look at their histories, they've been to the doctor looking for a urinary tract infection. They have trouble falling asleep. Their sleep is awful, trouble going to sleep, falling asleep, nightmares, REM sleep disorders where they're moving during their sleep and not supposed to, sleepwalking, falling out of bed. They have a lot of concerns, often with toileting, contamination fears. This is where the OCD comes in. Tremendous amounts of stomach and abdominal pain and body aches. And if you have a tick-borne issue in the background, there's a lot of bone and joint aches. So symptoms are not in the diagnosis rule out, you got to say, are symptoms better explained by a known neurologic or medical disorder? I just mentioned for the visual hallucinations, you need to ask yourself, is there a reason medically that they're having hallucinations? So this is where the DSM, which is the Diagnostic Treatment Manual, is important, because it also says, but wholly pretty much forgotten by my profession, psychiatry, that the first step in treating a health condition is to see if there's a medical or mental, if there's a physical thing that's happening that causes these symptoms. So for example, if I'm treating geriatrics and a person comes into my office and they're suffering from depression, and I take a good history and find out they had a heart attack within the last year, that is almost predictable, because a very large amount of people post-heart attack have depression that is stimulated by the heart attack. It's an inflammatory disorder. Now they have depression. And I mentioned before, the clinical diagnosis is done through history, rule out, supportive lab work, that not by lab work alone, which parents often want the labs because they're sure that's going to show them everything. But unfortunately, when their pediatricians do some of the lab work sometimes and it doesn't show up, then they definitely say you don't have PANS, which in fact you might actually still have. This is the basal ganglia again, and I'm going to show you because it connects to all sorts of other issues. Here's the multi-parts of it. It also works again on interconnection. You'll see why in a minute. But also here is where all motor movement occurs. All blinking, smiling, swallowing. So any tic that occurs out of the blue only comes from this area. This is the area where if you have Parkinson's, your dopamine is kind of being diminished. In tics, the dopamine is misfiring, and causing movement. It's also where executive function, behavior, and emotions are somewhat monitored, although emotions, as I mentioned before, is down the limbic system, the executive function from the frontal cortex. Disorders of the basal ganglia we know include tic, Tourette, addictions, because there's an award center in here, Parkinson's, tremors, Huntington's disease, which has writhing movements, Wilson's disease, it's just a copper disorder. So what goes wrong with immunology? I'm not going deep into this, but the main ingredient here is the IgG, which is, as I call it, the immune system in your blood, like the Navy. So it floats everywhere. It's in your lymph systems, your blood, it's in your brain, is in your blood, and it goes to war. So what happens is called cell mimicry. So the basal ganglia, as I mentioned earlier, this looks like strep all along the edges of the parts of the basal ganglia. There's little markers that tells the body what it is and what should interact with it. But those little markers look suspiciously like strep to the antibodies. So the antibodies get into the brain because this is called leaky brain, which is where an inflammation or an illness like COVID actually has caused leaky brain. And it seeps in, and then it says, oh, there's the strep right here. So it starts attacking it. So I say to the kids and families, it's got the wrong intelligence. It's bombarding the wrong place. But as a result, the shelling causes this area to enlarge. Brain scans have shown in basal ganglia, PANS, OCD, and Tourette's, by the way, this area is enlarged. So that makes you wonder, well, is OCD and Tourette's inflamed? It's an inflammation disorder. Maybe it's not strep, but maybe it is, or maybe there's some other reason it's inflamed. So this is why the basal ganglia is so important. So now right in the middle there, where right above the AMY, which is the amygdala, and the hippocampus is where all your short-term memory is stored. And the frontal cortex is your executive function and your focus and attention. Notice all these little black lines coming from the cerebellum on the right side. These are the dopamine tracks. So they created in cerebellum, they all go through the basal ganglia, and then they go to all these different areas. So when you see the diagnosis, you're seeing all these different areas being impacted. What's not on here is visual, sensory, but here's your thinking, here's your motor tic, here's your emotions, here's your amygdala over here again in the hippocampus. So it's kind of like this grand central of your dopamine tracks, and how that inflammation impacts those tracks then presents the symptoms. These symptoms can be really extreme. You can have barking, ticking, barking, licking shoes. Those are actually, I should say, that's wrong. It's not compulsion. It's licking. Licking shoes might be a compulsion, but barking is a tic. I had a girl in my office recently doing it. Motor and phonic tics, whooping, wringing hands. Sometimes this is the presentation. This is the only symptom sometimes, as I mentioned, tics. You can have terrifying episodes of anxiety, depression. The brain is telling them terrible things might happen, as I mentioned. And then there's this overlap between the symptoms and other illnesses that a person such as myself is trying to figure out, is there really any illnesses that I'm missing or truly being diagnosed? You know, I mentioned you can have ADHD already, you can have dyslexia already, but also if I'm meeting a girl in middle school, 7th or 8th grade, and she's having trouble focusing, I'm now wondering, is there an attentive part of ADHD that's showing, because this is when often you see inattentive type ADHD presenting itself when they enter more complex information learning in school. And I mentioned hallucinations. I won't go back on that. So what do we do to treat it? So first, diagnose it. So ideally you have a throat swab that your primary care will do, and you ask for it to be both rapid and you send it out for culture. In younger children or even in teens, a bottom review should be done, because if it's reddened area, which often looks like yeast, especially for kids, you have to differentiate between yeast and the reddened area right around the anus area. They often have strep in their anal area, and that needs to be swabbed with a little swab. Nasal swabs are done, possibly if you have a physician. I would like to do in the future, but I don't have a medical person on hand to do. Sometimes in the nasal swabs, you'll find staph and other infections. I had a girl who was operated on recently, and they found a pus pocket in her throat, and they had staph, candida, and one, I can't remember the third one, but 3 infections were in that throat, in a pus pocket that she was reacting to partly. Blood work, though, is one of the things I do rely on, and that is because if you have strep, even if they don't know you have strep, I should have said, throat swabs do not always collect the strep that's there, because the throat swab has to be done very rigorously, to the point, as Sue Sweeta would say, they're going to throw up on your shoes if you're almost there. You're just right before they're going to throw up. When she surveyed many kids at NIH as to what was the worst thing she did to them, including cerebral spinal fluid taps, they said the throat swab was the worst. They had to. But also, people don't always have it in their throat. They might have it in their nose, as I mentioned. They might have it in their stomach. They might have it in their anal area. So it's not always in the throat. And the reality from Dr. Pasternak, who's infectious disease at Mass General, will tell you that, maybe 30, 40, 50% of your lucky throat swabs are positive for strep, in fact, but they still have strep. So what happens is when strep is in your body creates antibodies, and those antibodies can be measured. You don't measure it right away if they have a strep throat, actually, because the antibodies elevate over 4 and 6 weeks. The antistreptolysin 4 weeks, the DNase peaks at 8. So often you see an infection or a sore throat that went away. You didn't even swab it. You didn't go to the doctor. You get out a sore throat for one day. It's done and over. And 6 weeks later or 8 weeks later, they start to have these symptoms. That is connected. There is a connection to the sore throat, or somebody in the family having strep, but not the child with PANS. And now 6 to 8 weeks later, you have a kid who's having a lot of psychiatric problems. There are additional labs, but some of them are often done: complete blood count, comprehensive chemistry, which is kidney, liver function, thyroid. Often primary cares do these. The other ones we often do is mycoplasma pneumonia, which is walking pneumonia. CDC sent out a warning last fall. It was so bad in the grade schools, they felt they needed to tell us, because it's not normally there. Mononucleosis, which is also called EBV virus, Epstein-Barr, herpes, and tick-borne illnesses, Lyme, Bartonella, etc. And then I do much more immunoglobulins, that's the IgG, plus a number of other parts of the immune system. ESR, CRP are inflammatory markers. ANA is an antibody in about the brain that's elevated a lot in any kind of rheumatologics, lupus, scleroderma, any kind of those illnesses. Ferritin and iron, etc., are being checked. And I check a lot of nutrients as well, going forward with all the other, and I look for a number of other viral infections. So this is from the PANS consortium called the PANDAS PPANS. Anyway, in 2017, they got together and made this graph and said, this is what we should do. This is the treatment model. It's three-pronged. It all needs to be considered. The first one is treating the symptoms with psychiatric medications, psychotherapies, and supportive interventions. I'll comment on that in a minute. Remove the source of inflammation with antimicrobials, meaning antibiotics, and then treating disturbances of the immune system with immunomodulatory or anti-inflammatory therapies. That's often the step up from just giving them. Treatment one, treating the symptoms, traditional. So behavioral and psych need to be managed alongside the illness. In fact, one of the traps parents get into is they want, now that they know it's medical or they suspect it's medical, they don't really want to deal in the psychiatric world. They don't want to be labeled. It's stigmatized. I fully know that. But in fact, without sometimes a psychiatric medication, you can't control the psychiatric symptoms while the inflammation is being treated. But some are not so severe. Some will actually, if you catch it early, a dose of antibiotics and some NSAIDs like Advil Relief, and take care of it, and you don't see that child again. But many times, because it's hard to get to people like me, it's often misdiagnosed. You're often in the psychiatric world before you even consider the fact that they may have PANDAS. Now you're deep in the psychopharmacology without a diagnosis. But it usually needs both if it's moderate to severe PANS symptoms. However, treating PANS symptoms with psychiatric meds is usually not the same as normal because they're very sensitive to very tiny doses. So if you give a Prozac dose of 10, which is maybe a 10-year-old's beginning dose, or you give somebody 25 that dose to begin with for like a week, and then you go to 20, which is an average beginning dose for depression. If you even approach 20 for many of these kids, you make them crazy. They get angry, irritable, manic, suicidal. It's not good. So everything, even if you're dealing with a psychiatrist, which I'm hoping some of you can, besides people like me, you have to coach them to do it small. And this is in the PPANS directory, which I referenced below. And so, but also the other thing is therapy. Although up here, they tell you to go to therapy. Well, if your child's mild and they can work on OCD and consider their anxiety, it works. But if they're really inflamed, they cannot take in therapy. Therapy requires that you have a thought process. You can remember things. You can organize the thought in your head. So when the therapist suggests you do something, you might actually be able to do it. So it's an overstatement in all of our thoughts who work with this, that to say therapy and a little bit of Zoloft will do the trick. Start there. If your child's totally debilitated at home, no longer able to go to school, can't dress, can't do their sports, lost out on basketball season, can't go out with their friends for a jaunt to the stores, you're not going to get anywhere with just therapy and a slight amount of serotonin measurement like Prozac. The treatment often more ends up with hospitalization with severe food restrictions, which weight loss requires hospitalization to keep them from becoming medically impaired, psychosis, aggression, severe tics. And psych units are ill-equipped to handle medical treatments, and med-surg units are not equipped to handle psych issues. Ideally, a parent would be allowed to stay with his child, and if you're on a medical unit, that's allowed. But if you go to psych, you're left on the outside and the door is locked between the two of you. So it's extremely important to use hospitalizations and emergency rooms if it's a threat to life and safety of someone, either you or your child, because if you're talking about an older person, they sometimes pull out a knife. They're not sure who they're going to stab, but their brain is telling them they got to stab something. You have to take hospitalization seriously as a way to prevent harm, but ideally, you don't get hospitalized. You try and work very hard to avoid it, but you don't avoid it to the risk of safety. It's a hard decision. I appreciate it, but that is a bottom line. But as a result of a child who can't separate from somebody's kneecap like their mother, and then you put them in a psych unit, it's trauma beyond belief, trauma for the parent, as well as trauma for the child. Also hospitalization is also denied by clinicians. They just go, yeah, they have to be hospitalized. They don't understand the parent and the child's relationship at that point, that they're so severe. The child's so severely needy of you. That is not traditional separation anxiety, people, that you would be hospitalized because you have separation issues. And their separation issues have to do with their OCD and the rules that they have in their head and how you play into them. Removing the source of inflammation, sometimes it's time, antibiotics and tincture of time. Many people come to me with having had an OCD event 2 or 3 years before in a young child. It kind of came and it went. That's because if there's no other inflammation, no other illness, no other strep, those antibodies that I mentioned that cause the problem do slowly decline in your body over a couple months. And then the solution is that you don't have a problem. But if it's serious enough, you need to move on to bigger things. The first is antibiotics. You'll hear Augmentin, Keflex, and Zithromax is most. And then we try about a month of those antibiotics and see if it moves the needle. Also, NSAIDs. I know this is online everywhere, but I do tell people if they talk to me and they're still not my patients, I say I can't officially tell you this, but if you do a standard dose of your children, according to normal directions for Advil, which is naproxen, or Aleve, which is Motrin and ibuprofen, you can see if you can move the needle and bring the behaviors down a notch. And there's a lasting remission from antibiotics. Now, why? So antibiotics are not there particularly to treat strep. It's often gone by the time you see the patient. And you're only seeing the antibody action. This is an illness of antibody misdirection, not the illness itself. So why antibiotics? This is what confuses a lot of medical people. They get very upset that we are giving repeat antibiotics. It's because antibiotics are anti-inflammatory. This is an NIH article published. So if you need to show this to somebody, here's your reference. And we try to discontinue them if there's no flares, no further symptoms. And we also use a lot of probiotics to counter the possibility of getting gut disruption, especially candida yeast in your gut when you're using chronic antibiotics. And then you might move towards a short dose of prednisones, which is anti-inflammatory, one step up on the treatment model. And then antihistamines are given a lot for behavior because they're calming, they're sedating. Guanfacine and clonidine are tic medications along with ADHD medications. Occasionally, somebody like me might use lorazepam or Ativan or something like that to bring anxiety down because, again, if I'm trying to keep somebody out of the hospital, I'm going to use as much as I can, including these meds, to lower the temperature of the anxiety and the aggression. I mentioned a lot about SSRIs, so I'll go on about that. Antipsychotics, yes, unfortunately, they're used. Many kids cannot tolerate SSRIs or any other antidepressant, so you have to use one step further. Even though they're antipsychotics, the chemistry of all antipsychotics is about dopamine and serotonin, the very two things that you're seeing represented in tic issues and in serotonin issues, which are Prozac, Zoloft, Lexapro, etc. Stimulants are rarely helpful, and this is a danger because you get diagnosed with ADHD by a person who says, well, your child's hyperactive and they're inattentive and they can't study and they can't go to school. So they have ADHD, let's put them on a stimulant. Well, they agitate more than anything. Non-stimulants at low doses can be useful. You go low and slow when you start these meds. So, okay. Cognitive supports I've mentioned, some of them are called CBT and ERP, which is exposure response therapy, which is the traditional therapy for OCD. There's a lot of supplements here, a few that are listed. Dietary, inflammatory, gluten-free, dairy-free, sugar-free, coloring dyes. But let me just be frank about this. If your child's barely eating, you're not going to take the only thing away from them that they're eating, which happens to be gluten and dairy. That would be a way to go to the hospital really quick. So although a lot of practitioners promote this, and I'm all for it, I feel like there's a reality about when one can actually carry that out and the age of the child and their cooperation, because the last thing you need is a child who will not eat because you're not giving them anything they can eat or they will eat, especially if their brain, remember I said they crave sugar and carbs. Parents need a lot of support. Thank goodness there's Facebook and a lot of parents PAN support groups out there. This is immunomodulator therapy, which is higher up on the list. This is where longer steroids are used, IVIG, which I'm not going into detail, but basically IVIG is IgG. Remember, I mentioned that's the antibody that floats around in your blood. They take thousands of people's blood and take out this little thing called IgG, and they give it to you. And that IgG carries all sorts of antibodies. So COVID and flu and norovirus, the antibodies to those are given in such a huge dose, it shakes up the immune system. Think of a snow globe and you're shaking it and all the snow settles back differently than it was before. That's what IVIG does to the abnormal IgG activity. Tonsillectomy, I won't go into, it can be helpful if you have a lot of strep issues. And then very rarely is rituximab, which is a drug actually used for rheumatoid arthritis and other autoimmune disorders, but also plasmapheresis exchange, which used to be available here, rarely ever here. Dr. Latimer is probably one of the few people, and there's a doctor now, no, Dr. Latimer used to do it, pardon me, and there's a doctor now in California that one of my patients just went out to see who did plasmapheresis on her, because there's no one here that believes PANS requires that. It is still available in all major medical centers, but PANS people aren't allowed to. So the other process and the most painful part probably of having this illness is what we call flares. Your child's getting better. Then they have, a recent one was they have a boy come over, spent the day with them inside. The boy's brother had strep. The boy actually probably was a strep carrier because every time he comes over and spends time with his child indoors, the child goes crazy within the next 3 days. If they're playing outside on bikes, never happen. Some people are carriers. Sometimes we check all members of the family to see if they're carriers, by the way. In early treatment, they're much more vulnerable to these relapses because the immune system, even in early treatment, is very vulnerable. It's still on hyper antibody alert. So any illness that I have or you have, anybody in the family has a little bit of a cough. That little cough means there's an activity of some viral thing going on. And you're putting that antibody, and the child picks it up, their antibodies go, whoa, we got to get going. We got to get really up there and really protect this person. And the antibodies get activated, which is bothering the basal ganglia. And now you're back down to a lot of symptoms. This happens a lot with pneumonia. I see kids have repeat out flares when they develop cold sores because that's a source for them. COVID's created a lot, I mentioned. And also very importantly in PANDAS, although not really recognized by the formal PANS physician network or the major medical centers, is that if you have a major tic disorder, underlying chronic tick-borne illness, and mold, and folks, if you live in New England, the chances of having one or both of those are very high. We live in a very wet environment here. I mean, we're not in Louisiana where water tables are super high, but there's a lot of granite outcroppings, and there's a lot of water in basements, and there's a lot of ice dam flooding and roof leaks. And you also have a lot of ticks everywhere. Now, ticks are really pretty endemic all over the United States, but in the New England area, it's really bad. And you can have a tick bite, of course, and never know it because the bullseye is a fallacy that it shows up all the time. It's maybe less than 50%. Ticks are often sesame seed size. They can drop off and you'll never know you. So why consider infection for a neuropsychiatric problem? I'm not going to touch on all this because I'm getting behind on time. But basically, the Spanish flu, I want to point out, is a SARS virus. And it showed all these medical issues, all these kind of psychiatric issues after it happened, 20%. COVID is exactly the same. About 20% of people after COVID develop psychiatric disorders. Bartonella is a common tick-borne illness. It causes rage, anxiety, and some strange looking stretch marks that shouldn't be on a child with stretch marks. Sometime we can talk more about that. Viruses also have been identified in schizophrenia as possibility, but very importantly, Epstein-Barr mononucleosis is now believed the cause probably of multiple sclerosis. Again, it's an antibody action that gets on overdrive that stimulates the immune system to cause an autoimmune illness such as multiple sclerosis. Why does your child have this issue? What would make them different than the next person who gets strep? Well, there's a number of things we know about these illnesses, including almost all autoimmune illnesses. One is genetic predisposition. And this is true, actually, this part is very true in autism, which I also know of, I believe, is a lot of inflammation in kids with autism. So family members have a higher rate of psychiatric illnesses. They also have a higher rate of immune illnesses. So allergies, Hashimoto's symptoms, lupus, multiple sclerosis, strep, etc. The sex difference is great. Males have a much higher rate of PANDAS than females. This is PANDAS data. But my experience is not true in the office. I see at least as many females, if not more, some days. You have gene mutations that happen. They're just starting to do genome testing and looking. There's a consortium of people from all around the world when we meet together for meetings that is working on trying to do this. Exposures to illness. If you get a strep infection, yeah, you have a strep infection, you get it treated. What happens if you have 3 in a row? That happened to somebody I know recently. What happens if you get strep? Then you get a norovirus, then you get COVID exposures, and then your family exposes you to the flu. So you've already got your antibodies stirred up, and now you got all these other antibodies being presented to you. I mean, you're getting illness spread droplet-wise, and your antibodies are just climbing. And so sometimes it's a sequential issue of illnesses, not just a single event. If you have strep and a single event puts you over the cliff, I have gone back and said, yeah, but let me talk to you about the pneumonia and the family illness 3 months ago. I had a family call me desperate because their son was extremely ill, had been hospitalized on and off for the last year and a half, really, really suicidal. And I said to the dad, by chance, did anybody have COVID in your family about 3 months before he went off? They go, yeah, how did you know? How I know is because that is the sequence I see with COVID. Really rapid deterioration, but a lot of eating restrictive orders as well, and suicidality. And also environmental issues, really important. Tick-borne illnesses are really bad immune disruptors. Mold is really bad immune disruptor, and we are living in a very toxic world. An example is glyphosate, and I didn't spell that right. That's an S right in there. It's an herbicide. It's sprayed on all grains you eat, unless you eat organic grains. It kills off weeds and grasses. So every soy, every corn patch is sprayed with this. It's also sprayed on it again to dry it up before they harvest it. So now we have glyphosate, and some people do not get rid of it. They don't detoxify it very well. It affects gut bacteria. It disrupts neuroimmune endocrine. It inhibits fats and protein digestion. It leads to inflammation, GI issues, and behavioral changes. So there are huge issues with and we can't always know these. There is some testing for this, but I, honest to God, don't know what I do with it if I knew it was positive. I'm sure there are people out there who do. But it's important to understand the toxicity. So as much as you can, get a hold of environmental working group, what they call the dirty dozen, which is the fruits and vegetables you do not want to buy if it's not organic, which exposes you to a lot more pesticides. And then trying as much as you can to use non-GMO food and non-hormonal driven. What is the roadblock to diagnosis? You can imagine now why it's hard to diagnose. Most practitioners are not literate. And often the PCP is the first contact, then they send you to psychiatry and neurology. Neurology, especially if tics are involved. And medical testing is just not thought of. You have a tic, go to see a neurologist. You have a psych problem, go to see a psychiatrist. Sometimes also, as I mentioned, the initial symptoms are not as severe, and then it's later on that things start to really snowball. And then by then, everything else is blamed on another diagnosis. I've had some kids who are unbelievably ill in consultation, and it was blamed on the fact they were bullied and that the parents got divorced. And I'm thinking, a person does not lose 50 IQ points because they're bullied. They might lose in depression some verbal IQ points, but not visual motor. I mean, bullying doesn't harm your visual motor skills. And many doctors still believe that PANDAS doesn't exist. It's, quote, controversial. There's an article about this in terms of example. But very importantly, for those who have not already heard and been horrified, the Academy of Pediatrics finally came out with a statement about PANS being real. The last publication I used to show on this slide was 2017, where it was highly questionable. However, the way they decided to present it is they cherry picked through the data. They presented mostly what was true in 2012, which is you have to have a strep throat. You have to see it as a strep throat. If it doesn't look red, you're not even swabbing it. If it's not positive, you should not order meds. Not order blood work and not put them on any more than 10 days of antibiotic. Amen. It's good that they finally said it really is real, so they don't denigrate you so much. But in fact, the rest of it's pretty horror show. And I know a lot of you were traumatized by just reading the document. This is I used to show a lot of research, but I'm just going to refer you to the fact that this website, the Aspire website, is a wonderful collection of any and everything you want to know about an article. If you, by the way, see something before it's published in there, Gabrielle True, I'm sure, would be loving to have you send it to her so she can post it. What do parents fear? They fear a lot. They fear violent and dangerous behavior, how incapacitated their child is. You know, I call it the invasion of the body snatchers. Where did your child go? Because it's not the one to sit in front of you. The symptoms returning, the flares, cause lots of post-traumatic stress. There is not one person, I believe, in this world who is a parent who has a child with pain that is not traumatized by it. Children are traumatized by it. Luckily, they do not remember as much about it, especially when it's severe. Their memory is kind of shaky, but yours is not. You remember everything. They also do remember not being able to think clearly, write, read. They have some irrational behaviors. Many of them have lost their friends. They've lost their life. They go, they aren't in school for 2 or 3 years, or they have to change to a sped school. And they have all sorts of medical interventions, psychiatric medication trials that often are pleasant, etc. I want to point out that these slides are also produced by Melissa Glenn Hyman, a wonderful therapist who's really great at helping families in this field. And some of these things are from her. And family impact is huge. Everything, they see and hear everything. Siblings are really impacted because they see and hear everything that's going on, and they often lose attention. They often lose time with their family. They've lost their family dynamic that used to be their family. The marital stress is huge. Often one parent is often the mother, sometimes the dad is home managing the behavior. They've stopped working because they can't have both parents working. The financial costs are huge. And there's a lot of discipline agreements. Is this willful or is it not? Now, especially when you're coming out of an illness state or a flare, it's very raggy. It's kind of like one day they're good and one day they're not. So then there's a sense of, well, they did it yesterday. This must be willful if they can't do it today. And are the family extended giving you support? Many of them are critical. Many of them are just telling you you're a bad parent. If you just discipline them more, they would go to school. They would get dressed. They would and they don't get it. Another thing is the impact is controversial, as I mentioned, and you're really being told the normal child is now a psychiatrically ill child, and they're kind of describing illnesses that are chronic, like they're going to have this the rest of their life, especially if it's bipolar or schizophrenia. And you're fighting for their life. You're fighting for their life, especially if they are always talking about suicide or they're doing very dangerous things. A common feature is trying to jump out of a moving car on a highway. It may not be that the child wanted to at all kill themselves, but they're panicked. They're panic stricken. They lose all sensibilities and they try and jump out of the car. Or grab your steering wheel. That's another one. The impact on the family, as I mentioned, is huge. And parents need support and not blame, not derogatory sentences from their doctors. Support, assistance, navigating resources, information, partnership. We have looked at Foundation. We have PANDAS Network, which gives a lot of support and a lot of information for this. And you yourselves are out there helping each other so much. The roadblocks at school are equally daunting. They can be identified as PANDAS, and then they show up at school, but they're not always easy to identify, especially if the behavior is mostly at home. In a medium level OCD, the child will button it up, bring it to school, sit on it all day, and come home and display it in great, huge colors. Same one with tics. Tics are suppressible. A child can tick, tick, tick. You get into school, the teachers say, no, we don't see any tics. Then they come home and they tick, 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 and you go, what is wrong? Am I just at this willful? Why am I seeing it and they don't see it in school? If they have OCD, they're quiet, they're covering it up. They're working really hard, so they come home exhausted, and that means more rage because they've been working really hard to manage that OCD in the classroom and not look strange. Communication is not often extensive enough. It's hard right now for teachers. It's hard for everybody, but they often don't hear you, or they hear and you go, oh yeah, we know about PANS, but their behavior does not support that statement. Many of them have already had IEPs or 504s, but if your child's never had one, this is a whole new language. You don't even have an idea where to begin. What is the difference with those things? How do I ask for help? The other thing is often the schools switch. So even within the same district, if they've gone from middle school to high school and now they're different, there's nobody who knows that. Particularly grade school to middle school. They don't know what the child was like. If it's a second grader that's now acting out as a fourth grader, the school knows something's different and the nurse knows something different. But if you switch schools or you've switched even up to a different grade level, different building, that history is not communicated. They don't bother to tell you the kid was wonderful. You don't hear about it because the kid just came to your classroom. They have all sorts of issues. I've mentioned a lot of them. These are more descriptive of them, but they also have a lot of difficulty with their visual motors and art and creativity. They have huge sensory issues, so they don't want to go to cafeterias, art, music, any of it. They can't stand it. Gym. Oh, huge gym one. Physics. They have a lot of perfectionism. They also rip their homework up, hide it. They don't tell you they've got it. They're unable to make decisions. And here's there's a book I refer to in the bottom. And I just remembered, I just put 2 of these. I hope it's in order. These are some essential things that one wants to communicate. These are essential ideas, what kind of plan you think on plans. There's also lots of this out there about the kind of things you put into an IEP or 504 plan. And these 2 I've adapted from her book and a lecture I heard from her give many years ago. This slide should have been up there with fear for parents. This is the parent slide. Practitioners lack information. I've already spoken that. But in addition to that, they do not listen to you. They have seen this child. They've raised this child as a pediatrician for 8 years. And now the child's under their table acting weird. They have this look in their eyes that's totally off. It's not looking like the same child. They've missed it. Their eyes are dilated. And they're just saying, oh, it's okay, Mom. Or it's like, yeah, they just need to go to a psychiatrist now or a social worker. And, well, let's call it separation anxiety disorder. Let me give you a little Prozac. Now, that may be all true, but that often doesn't work real well. But one parent, when she went back to a doctor and he said, why are you going to that so-and-so person? It wasn't me, but it was another treatment center. They're just quack. You just walk in and they spend your money. And the mother bravely said to her, Dr. So-and-so, please don't degrade my ability to, everything you tried did not work. So please do not denigrate me trying to help my child. You shut up. Most parents don't even say that. They just leave that practice and they disappear from that practice because they have to go find somebody that is not going to denigrate them. There's lack of resources, lack of compassion, the blame for the child's behavior. Women, especially moms, I can't even begin to tell you the horror stories, but I'll give you a couple examples. You're in the emergency room, Mass General, which has the PANDAS clinic, mind you, and the psychiatrist says, I really think this is because of your OCD, that your child is head to toe tics. So if you could go home and fix that, that would be great. You're not heard. Emergency services are really ineffective. And just to go to emergency room now is a hazard to anybody's health. And psychiatric units often dose very high because their goal is to stabilize your child and get them out of there. So they're often very aggressive with those medications. How does it display in school? This is really interesting because it's not quite what you would imagine. As I mentioned, remember, the OCD is not coming out necessarily. The tics they would see, but not as much as at home. So it's a lot of obsessive behavior, erasing, reassurance seeking. They keep asking questions. In SPED schools, they're just more class to the staff, so they're kind of keep asking questions. They're very distracted. They get stuck on tasks. They avoid things. They shut down a lot. They just put their head on the desk and stop working. And their physical complaints are often very high at this point. So they do have real stomach aches. They do have real joint pain. They do have real back pain. But everybody's saying to them, this is your anxiety. They have a stomach pain. That's because they have anxiety. They have a headache. That's because they have anxiety. So now you keep getting directed back to the psychiatry. The learning process, as I mentioned here, again, all sorts of areas. And anxiety and OCD hugely impact these, even if it's not just the brain dysfunction from the basal ganglia. Anxiety and OCD interfere with functioning, working memory, processing speed. If you're really anxious, think about yourself really anxious and somebody tells you something, how hard it is to remember what they just told you when you're in a close panic. You can't remember because your working memories in a major anxiety level is shut off, which is why your children often don't remember the really dramatic events of PANS, because their working memory in a state of high adrenaline anxiety doesn't record. How can school help? These are many different suggestions. Some are already in Pat Duran's work. Reduced excused homework, flexible schedule, extended time to test, frequent breaks. Appoint a person to decompression state, place to go, sensory tools, positive reinforcement, and stop the bullying. This is a big one. They're often bullied because they start to act weird. They're shy, they're withdrawn. People will say, go make sure you're seeing a therapist because they read the PANS guidelines. They say they know PANS, but you and I know if your child's really disrupted, they aren't going to do. Many people have tried out there. I know you've sat in front of therapists a long time and you go, this isn't helping. However, much of the time it does help the parents to get support when they're in this state. Sorry for all the typos here because I enlarged this so you could read it better and I didn't recorrect the spelling. So there are accommodations for obsessions and compulsions and anxiety in the plans that you need. Very importantly, what kids want teachers and staff and parents to know. Just because I look healthy doesn't mean I am. I wish I looked as sick as I could so you could see my pain. Some days in my brain just won't let me learn. I really, really want to go to school, but I can't. I hate being different. I'm so lonely and no one understands. I'm not lying. Please believe me. I don't remember things. Sometimes I can't do it. I just can't do it. I try as hard as I can every day and look different every day. Looks differently every day. Again, thanks to Melissa Van Hyman for putting this up. The school nurse is a key picture because you do need to talk with them about illness, about exposures, and they're the first person that can often tell you around recent strep outbreaks in the school. But remember, the nurse does not always know when you're strep. If it's Friday night and your child has a sore throat when they get home, you take them to urgent care, they got strep throat, they get on antibiotic. By Monday, they have not missed a day of school, they're back in school. If you have it done Monday, they miss a day, they're back in school. The only reason you have to tell a nurse is because they're out 3 days. But nurses often get told about abrupt changes in behavior and they're consulted to by the teachers or bringing it up with the teacher. So they're really key to being a good relationship with them. And again, you're going to also ask with a nice call to the teacher if they would please tell you if anybody in the classroom has strep, emphasizing, because they go, we can tell you who it is. I don't need to know who it is. I just need to know if it's there, because if they're in proximity to that child who's shedding, remember, we shed infection 2 or 3 days before we get the illness. So COVID is 3 days, strep is 2 or 3 days. Kissing sickness is just, sharing drinks for some kids in high school, especially. The kid can have strep and your kid's getting it before the child shows up with strep. Same thing in your families. And if the teacher's been diagnosed, this is a big issue in a community that you all know who you are, where a classroom in one school just had so many kids with PANDAS. It was just ridiculous. And it turned out the teacher slipped one day and said something about her son with strep, and we always thought maybe she also had it.
Peggy,
Yeah.
I just want to say maybe 5 more minutes or so. Is that
Great.
all right?
So this is a sample letter. You might want to redo it. That goes to the school, that the school will actually put out in your grade or class to let the parents know that it's important for them to tell you that they have strep. There are some kids who have such bad strep. It really, really totally inhibits their function. So some of these are very appropriate. Not everybody needs one of these, but you have to think about it. These are resources for PANDAS. The PPANDAS is the physician network. There's a wonderful article to give to your primary care person, seeing your first child with PANDAS. Pretty much like the New American Academy, although a little bit better written. That's a really good resource. Aspire, as I mentioned, is a wonderful resource for webinars, school instruction. Tons of research is recorded there. And our Dear Look Foundation here in Massachusetts, which has got a lot of parent support, grants for treatment, and a lot of resources. And then again on the web, there's tons of other places that are giving you information. These are books. Some of them are older because I'm not always kept up on everything, but these are the 2 main ones on schools. This one by Candelaire Green is almost like a textbook, so you kind of use a section of it. You don't think you're going to sit and read it all. Pat Duran's book is much more readable in terms of giving it to educators, like giving it to the school and saying, please look at this, or the SPED directors. Saving Sammy is famous by Beth Maloney, her original book. And then the really good book still, even though it's 2013, is a pretty good explanation about what PANDAS looks like. I don't always agree with some of the stuff in the book, but that part about what is it and how it presents is still very accurate. And then I just mentioned these 2. I'm sorry. Oh, these are some great kids books. And A Pickle Over PANDAS, A Child's Introduction to PANDAS, and My Story About PANDAS. One of the best ones I'd say is a mix between pictures and words. A couple of these are more pictures, a couple of these more wordy. And then when your child has Lyme disease, it's a parent survival guide there. There's a lot of other books on Lyme brain. And then another picture book for PANDAS. This is for family educators. So this has a lot more words in it. Brain Under Attack is another one around PANDAS and autoimmune encephalitis. This illness is referred to as autoimmune encephalitis by some of the medical staff. However, I need to inform you that your primary care physician and even neurologist that you might run into think that autoimmune encephalitis looks like a person in their ICU who's seizing and almost dying, because there's a very specific illness that happens with autoimmune encephalitis, like a tumor on your ovary for a girl, or a brain inflammation from bacterial meningitis, or a very known one now that was only discovered and named maybe 20 years ago, where an antibody attacks a certain part of your brain and causes autoimmune encephalitis. This was made famous by a book you might all know called Brain on Fire. That's a very specific AE event, but that's what they think autoimmune encephalitis is. So they're like, they don't know what they're talking about. Are you crazy? Your child's going to school. Their child's sitting in front of me. They don't have autoimmune encephalitis. Don't even bring it up, is my experience. And there's some more here around students and educators around Lyme, as well as, is it PAN? This is an older nurse out of 2015. Is it PANS, CANS, which is another way of describing PANDAS. Closing thoughts. Kids do get better. For the people who come to my office who've been sick a long time, it's a long recovery, just to be really frank about that. Kids who come in early, like first time, they just had strep 2-3 months ago, they're just starting to act out, and they don't have a long history, often recover quicker and better. But if they have an underlying tic disorder, which I don't identify for some reason, they could get better, and then they're back in my office with mycoplasma pneumonia. Then they get better, then they're back in my office with some other illness. The immune system just is too disrupted. Earlier diagnosis, better treatment outcomes. It's a spectrum in terms of how it presents. Certainly people in my office are much sicker than some others. Not all patients will have all the symptoms. You only really need one of the beginning ones and one of the middle ones, 2 of those major lists. The symptoms are relaxing and remitting. It's a chronic illness for many people. That's the flares coming and going. And you really have to be a partner as a clinician with the family. It takes a whole team. Please don't blame the child or their parents for their illness. And this is medical. I keep saying the symptoms are psychiatric, but it's a medical illness. The metaphor I give families is if you had a gaping wound on your leg, I come along with bandages to keep you from hemorrhaging to death while you're trying to treat that wound. But the psychiatric medications will not change this illness. It's really important to understand. But they are not to be avoided because you're often leaving your child in misery when you could actually relieve some of their symptoms and help them, help them have some semblance of reasonable ability to engage with things that they might want to do. And I'm done, Sheila, if you want to open for questions or share questions.
Yeah.
Do you want me to share my slide back or get out?
You can stop sharing. Is that what you?
Yeah. Let me see.
Yeah, if anyone has any questions, you can put them in the chat for sure. It looks like there's one. I can read it. Is there a connection between autoimmune encephalitis and developing visual snow syndrome?
I have seen visual snow syndrome in major inflammation. I think the 2 cases I can be sure about are COVID, post-COVID. And what visual snow is if you're looking at an old black and white movie and it's snowing in front of your eyes. Sometimes it's on one side and that's the whole, it's a neurologic symptom. But unfortunately, this person was told by an ophthalmologist that, no, it's no big deal. Well, it is a big deal. It means there's something wrong in your neuronal occipital. Remember I said it's in the back where a visual is? There's something in the dopamine tract that's bothering that area. Other things kids have described are blue hazes. These are the visual hallucination kind of stuff. It's not a hallucination of snow, by the way. And then you have to differentiate. Sometimes you see colors and shapes, funny shapes when you have a visual migraine. So if there's a headache attached, you have to kind of sort that out. So it's still helpful to have a neurologist checking things out if you have this visual snow, or a neurologist, I'd say.
Okay, here's another one. Tips when perianal strep won't clear. Azithromax helped at first, then didn't. We haven't had a clear swab in many months.
one would usually use other antibiotics that I mentioned earlier, cephalexin, augmentin. I did find out augmentin, which is one of the god awfulest liquids around, is now able to be flavored with bubblegum or cherry or something like that. So that would be another option. But my guess is if you've tried it, you may not have been on it long enough. Just remember that this often requires long-term treatment, not what a pediatrician is likely to do. And to be fair to pediatricians, just to remind you, they are monitored how many antibiotics they give them for how long, and they are not allowed generally in their practices to give more than 10 days at a time or 2 weeks. Sometimes you can beg them for 2 weeks, especially if they see the results, but you cannot expect them with rare occasions to continue long-term antibiotics. That is a real hazard to all of you.
Okay, here's the next one. Can you speak more to visual motor tics, visual field loss, one pupil larger than the other, which is anisaccharia?
I haven't heard that, but the pupil dilatation is usually bilateral. If it's one, I would suggest to me that only part of the brain is creating that. Often it comes along with hyperadrenalization, which happens around 3 to 4 in the afternoon. Your child starts, all the symptoms start getting higher and louder. And those are often when the pupils dilate, which is called mydriasis. What was the first 2/3 of that question? I got the back end of it too.
Visual motor tics, visual field loss, and one pupil larger than the other.
If there's visual field loss, then I would think you'd need a more thorough evaluation neurologically, perhaps a CAT scan, MRI, because that's more neurologic for sure. And it could be caused by PANS, but you don't always know it is.
Could it also be like Lyme?
Lyme
has some visual stuff, doesn't it?
Possibly, yeah. But again, it's neurologic if it's going on. So you'd really want to be clear neurologically. And then you might go back and see if Lyme's there. In other words, if all the scans are negative, all your exams are negative. But something like one-sided is often like migraine. Migraines are almost always one side, not if you have headaches all the time this way, it's often sinus or stress, but migraines are almost always one side.
Okay, sibling support group suggestions. I'm trying to think. Sibling support group, maybe.
Well, it's been suggested, and the problem that happens is getting them to go. It was tried a number of years ago by New England PANDAS people. It's still a huge need if anybody has a desire to start one. I think what they found in the sibling group, or even the patient group, they try to do patient groups, get teens together and talk about it. Many kids in the middle of this illness don't have words to describe it. It's often kids who are healthier that can talk about it. But it's a huge need for siblings, but it's not done. So there's where the therapist can be supportive also if they understand the illness to give support. But it's a really big need. I don't have a full solution.
Okay. Is there a specific brain scan that can be done to show what's going on?
I want to say one other thing. I've also had requests for grandparents groups from grandparents who are feeling that they really live with this. They've waited by it. They're participating in it. And they don't feel like they have any area of support, by the way. And that's true. Now the question, yes and no. One of the huge issues is I had an MRI and it shows no basal ganglia inflammation, no enlargement. That's because the studies that have been done in PANS for basal ganglia, OCD, and Tourette are very specialized, very targeted basal ganglia measurements, which are not done in normal MRIs. In fact, unfortunately, when you look at the workups, and even though in the PANS consortium and that whole diagram you can see when you look, has MRIs, CAT scans, cerebral spinal fluid taps, rule out. Very few clinicians ever do them in PANS treatment unless they see things that tell them they need to. So like a visual change would be one of those things you might want to be doing. Is there something on the motor cortex that shouldn't be there? fMRI, which is F is functional MRI, which is where you're getting an injection usually, shows volumetric changes like is the hippocampus smaller than it should be? Is the basal ganglia smaller, bigger? Is the frontal cortex change? very few people do those, and there's not any real research in hands about that. The PET scan, which is a different kind of brain scan, it does much more detail. Often I believe it's infused. Some doctors, like Dr. Younger in New York, and I heard of a neurologist who, well, he didn't do a PET scan, have identified, have done them. Dr. Younger in New York has done them. He also does muscle biopsy, tissue biopsy to see if you have what's called small fiber neuropathies. In other words, all your neuronal tracts are coated with myelin sheath. It's white matter in your brain. It's a fatty acid cover. It's what degrades in multiple sclerosis. Anyway, he's seen those areas damaged in PET. So, but it's not really good. There was an MRI study by Dr. Williams, and I can't remember if did he publish that, Sheila, at one point? I don't recall. But you might look up to see if there's an article by Dr. Williams with MRIs for kids with PANDAS. But basically, CAT scans, MRIs, they really only show more gross abnormalities, and only in the higher level where injections are gone in, where they inject glucose that's radioactively monitored so they can see where it goes. That's what activates, and/or structural like PET scans and fMRIs, and those are not typically done. And you're not going to have an indication to do it unless you have a really seriously abnormal neurologic presentation.
Next one. Could you explain what it looks like when a child has an onset of PANS in elementary school, but the onset was missed? Can a child be diagnosed years later as a teenager? My doctor has been dismissive about PANDAS.
The answer is yes, but it takes a very thorough eval. So as a consultation person to Sheila's school, we see this a lot, where all of a sudden you can find reports that the kindergarten or first grade teacher said, what the heck happened? Your child can no longer color. They can no longer do simple subtraction. At second grade, they can add, subtract, and read, and now they can't do that. The parent will report a sudden change in behavior that they noted, but and then it resolved. Or they had a frequency of bedwetting, and then it resolved. They had an onset of OCD, and it resolved. But often in school reports, you can see, or the teachers will tell parents something changed with your child. We see it even as young as preschool sometime, where the preschool teacher says something about, something changed. Middle schooler, I have a 24-year-old now who I could trace back to middle school, where she said she was very popular, most athletic in her class, she thought. And all of a sudden she showed up and was mute at school. She couldn't talk. Her anxiety got high, her schoolwork began to degrade, and eventually she couldn't play a sport because she could no longer hit the ball correctly that she was working with. Her eye-hand coordination just disappeared, and that was middle school. But I met her at 24. So it takes some time. This is part of the work, as to how to really go back and look. Often we sometimes have parents pull medical records and see how many times they called the doctor about a sore throat. I've got tons of reports for parents that they journal it over time. They can collect it, and they go strep, no strep, no strep, no strep, no strep. But the sibling has strep, or they had a sore throat, but it was swab negative. Here's a kid who has strep but is not swabbing negative. Multiple ear infections, nasal passage infections, all this respiratory stuff that kind of can chronically hit kids. Kids with severe allergies and asthmas that have not been treated. Also important. Eczema, psoriasis, those are all autoimmune. Eczema and psoriasis are inflammatory issues. So if you're having a lot of them, they add up.
Okay, I'm just trying to, I want to just name, Dana and I are not clear if in 4 minutes it's just going to shut off.
Okay.
It's the webinar is scheduled
We'll
to
say goodbye now and wish everybody well.
Yeah, it may keep going, but I'm just saying, if it shuts down, that's just how we're rolling tonight, I think is what's happening.
Apologies for starting 10 minutes late with my screwy computer.
Oh, no, it's all good. Okay, there's a question about what do you do for mold, which is a big question, and we have a few more. So do you want to try to?
So I generally send you to a person expert, because I can't say that I'm at, but basically there's two pieces. There are medications that treat for mold, and there are a lot of supplements and binders that help pull it out of the body. And you generally need both. You also have to review your home. There are some very inexpensive do-it-yourself kits, both where you suck the air in into a little valve, or you set a petri dish out. There's different ones to collect, grow mold yourself. But you also have to remember, where did your child live all their life? Because there's a number of families that live in dry housing, but when they used to live over here for 5 or 7 years when the child was younger, they were in a wet house. If there's a water heater break, if there's a shower dripping and your child's bedroom is below that shower or near that shower. And we found also, where did they spend COVID? Did they spend it in the basement? Did they spend it next to the room that's actually been where the leak was happening? Where are roof leaks? Parents often tell me they know they had a leak, they ripped everything apart, or they just redid it. The kitchen was redone. They had a huge flood in the kitchen, but where did that water go from the kitchen? Did it go down below in the walls? So then the second piece is, once you do it yourself, or you hire a company to come in and actually measure the air professionally in your house, in your attic, in your back end. Sometimes it's in the HVAC system. Air conditioners particularly are notorious for holding mold. And then if it's there, you remediate the house, which is not inexpensive, but necessary if you're going to stay in the house. But also, new builds are not guaranteed. As a mother, Peggy, bless her heart, she really drugged me into mold and said, you have to pay attention to this, Peggy. And she's become an expert. And she reminded me that new builds, if you watch them, they're out there in all the weather. All the rain goes in, all the snow goes in, and then they close it up because that's what on schedule they're doing, and not drying out the wood before they close it up, especially in a winter. So you can have wet wood in a very new house that can become problematic.
And I think a lot of families I've worked with have also said that really regulating the immune system actually does start to help. But mold is a big topic. Okay, I'm gonna go to the next one. Let's see. Okay, if IVIG and medication regime of antibiotics and anti-inflammatories are working, and then labs show a Bartonella, fish test comes back positive with high levels of mycotoxins, do you recommend changing some of the treatment, or do you stay with what's working?
Well, the problem is the people who are doing IVIG and antibiotics are not the same people that are treating mold and Lyme, generally speaking. So you're often now entering into the world of multiple providers, all giving you something different to do, and more supplements and medications to manage, which means your whole counter in the kitchen is filled with these things, and your children can be overwhelmed, as can you be. It's hard work to keep it all straight. It's expensive many times because you have to seek reimbursement for a lot of the services, but you're usually dealing with 2 worlds, 3 worlds sometimes. You're dealing with tick-borne issues and mold, and anybody who's doing IVIG and antibiotics is generally in a major medical center, or somebody like me. I'm not ordering IVIG yet, but you're dealing with more than one person usually. There are some naturopaths that try and do it all if they're allowed to prescribe, but they don't order IVIG, they don't give IVIG, they don't, they're not administering it. So if you've got IVIG and antibiotics, you're probably now entering a different world to treat Bartonella. This is a chronic illness now. It's not a new onset usually that you're running into.
Okay. All right. Let's see. There are only a couple more, so we'll just.
Okay, see if we can get them in.
Yeah. Okay. A parent said that the Somerville Adolescent Psych Inpatient Unit is PANDAS friendly. That's exciting.
Oh, that's news. Somerville, though. Which hospital? They could tell us.
I don't know. Yeah, if you can, that'd be great. Our biggest PANDAS symptom is clothing OCD, needing a certain fabric every day, etc. We've done therapy for over a year, CBT, fear ladders, exposure therapy, and stalled out. What else should we try?
Well, have you been on antibiotics, NSAIDs, and then treatment for the infection and the inflammation? That's kind
of what I was thinking too. It's like if it's not getting better, like ERP isn't going to work if there's still inflammation. So you may just need to go digging a little bit.
Yeah. And the child will sit there and say, and then they go home and go, I'm not doing that. Either by action or by words, usually both. They just say, yeah, and then you keep trying. You keep trying, you keep trying. I will say, though, therapy is really good with a therapist on ERP if the parent is becoming more and more in part of the ritual. So a ritual is seeking assurance. So if they ask you the same question, I was taught this by OCD experts. If they're asking the same question over and over again, you've got to know how to say, I've already answered that. The rule I was taught, 3 strikes and you're out. You say to your child, okay, I'm going to answer that question 3 times. On the 4th time, I'm no longer going to answer it. And then I'll set an alarm clock or something to appease them. That if you want to ask that question again in an hour, I'll answer it 3 more times. But sometimes you can't do that. When your child's going to literally rip their hair out of their scalp if you don't answer the question, you don't bother with this. But parents do need to learn, how do they get themselves out of the shower with the child? How do they get the child out of their bathroom? How do they, when they can't go to the bathroom without their child? How do you break the cycle that your child has now looped you in? You don't realize you are now part of the ritual when you are being in this verbal engagement, or you're helping them get what they want as part of their ritual. Now, I understand when your child's really, really sick, you cannot avoid that. But there is a point where you and them, especially if your child's trying the therapy, you've got to learn your role. It isn't just the child.
Okay. Okay, let's see. People are asking about how to get the Zoom. I'm not exactly sure how we're going to do that just yet. I know the Dearborn families will definitely get the copy of the webinar link. And I am not sure if,
put it out on.
Yeah, I can put it out on maybe some of the PANDAS on the PANDAS pages.
Yeah.
Think of that. People can definitely email me at Dearborn. You can and I can see if we're going to share it out largely, then I can share it with people, but I can try to put chat. Okay, but one last one. My child has many of the symptoms you described, but not a sudden or acute onset, more like over months, and especially ADHD, which was diagnosed years ago, but is much worse. Can this still be PANDAS?
Yes.
Yes.
So many times, because the infection was not known. It may have been a strep infection and you don't know it was there. Many people have mycoplasma pneumonia. It's called walking pneumonia because you walk around with it and then it kind of goes away finally, but you might have had it. We see a lot of kids who had periods of time they were really tired and fatigued, and they had positive there for Epstein-Barr. You didn't know they had mononucleosis, but in fact they did. So often it's months and months later. So even though this is where the hazard of the NIMH, of Dr. Sweeto's original article, she focused on PANDAS deliberately, she focused on strep deliberately, because she needed to do research and that was the only way she could do it. And now the AAP, American Academy of Pediatrics, is now reinforcing this, which is it has to be a sudden onset, like the next day. Well, that's not realistic when I just told you that the antibodies often don't peak for 4 to 6 weeks. And so the distance between the insult is often months to years away from the process continuing. Also, you often have waxing and waning, and then there's a point it goes, as we say, off the cliff. So there are many kids, when I go into their history, have actually had PANDAS events. I recognize them by the nature of how you describe them, or a period of time where you had some OCD going on, or a tic that kind of came and went, or a separation anxiety that was just not a typical one. Maybe they had a decline in their academics for a period of time. But often then there's an insult or some physical illness that hits the antibodies so hard, the body and the whole immune system, or the immune system's degraded by mold or tick-borne, and now it's so much more vulnerable. And then you get a whole level of symptoms that becomes debilitating. So I call that off the cliff. And a very interesting story is that I had a parent report to me after their child had strep January, February, March, that in the middle of March, with no one knowing what was happening, the math teacher said to the mother, I don't know, she's just gone off the cliff. But that was the language they used. That the math teacher saw it, whereas nobody else did. And they didn't have PANDAS you would recognize at this point, but the teacher saw that something happened to the math skill.
Okay, one last one, and then we're going to wrap up. We've tried antibiotic and anti-inflammatory treatment twice. We did not, I'm going to leave out the doctor's name, but we did not get reduced symptoms of the OCD. Currently trying therapy and SSRI with little improvement. How many years does recovery take?
I think you'd first have to start about checking to see there's not Lyme or tick-borne illness or mold. As I mentioned, the major medical center people. So at major medical
This
center,
is a major medical center person. And I would just say, if you've only tried like short courses of antibiotics and anti-inflammatories, you may need longer course. But if it's PANS and PANDAS, therapy and SSRIs really won't. They will help. They're the third prong of treatment, right? Sorry.
they won't move the needle to health though. So the recommendation is, so just to recall that Dartmouth, Stanford, Arkansas, Harvard, MGH, they do not recognize or test for chronic tick-borne illnesses or mold. And so many people have had traditional treatments, including IVIG, where the child gets 60% better, but they do not get close to 90% better. And this goes on for years. And it isn't until everybody says, well, that's as much as you're getting, or we can't, why would you keep going if it doesn't help? The parent ends up, and then you have another flare, and then they find somebody to check for Lyme or mold or tick-borne illness. And that's the golden ticket. But by then they're, several years further into the illness and things are worse. I didn't mention some accompanying things that happen with mold and tick-borne issues called POTS and mast cell syndrome. There's a lot of other illness states and immune disrupted states that one picks up along the way when you have had long-term chronic inflammation.
Okay, well, I'm
On
gonna,
that dreary note.
we're all gonna go to bed, but okay, so if folks want to ask for a copy of this recording, I'm not sure who we're giving, I'm not sure what we're gonna do just yet, but you can email me at scouch@dearbornacademy.org. And other than that, oh, it's Cambridge Health Alliance is yeah, that makes a lot of sense. Cambridge Health Alliance is we've had good experience with them as well, right, Peggy? We've had students work there. Okay, Peggy, you are a hero. We always love having you. Thank you very much. I'm going to see you in the morning, I think, which is exciting. So,
yeah. Okay. Good night.
Okay. Good night, everyone. Thank you. Oh, I have to stop recording. Stop recording.